We discussed neurology neuroanatomy so extensively. The other day AIMS exam, one of the favorite questions was Cliver-Bucy syndrome, which we have discussed in limbic system, right? So Cliver-Bucy syndrome was a question, and the limbic system structures that get degenerated in HIV encephalitis was another important question. So there were quite a good number of questions of what we all have discussed. Similarly, in the ophthalmology ENT also, the mastectomy, myringotomy, so many issues. So that's the reason none of you need to worry at all about when the syllabus will be completed. It will be definitely taken care. So let us make the great start. I hope the voice is clear to everybody, yes, the lesser tubercle, it is very important because it is the point of insertion for the subscapularis muscle is what need to be remembered. We were discussing about the intertubercular groove. You have the long head of the biceps, it will be passing through, the tendon of it is passing through the intertubercular groove. It has one lateral lip which is the site of origin for the pectoralis major, and teres major is the one which takes origin from the medial lip, and latissimus dorsi takes origin from the floor. So much of importance is there for the intertubercular groove is what you need to remember. So in summary, doctor, you have a greater tubercle, you have a anatomical neck, the lesser tubercle, the intertubercular sulcus is what need to be remembered, and the various muscles which are in close association. Now the surgical neck of humerus, this is one thing many times questions come. Distal to the tubercles, there is a narrow area which is basically called as the surgical neck, which is a very common site for the fracture. Is what need to be remembered. Two important structures in surgical neck of humerus you should never forget. Tomorrow in orthopedics also this is the same issue. You see, from the posterior corner of the brachial plexus, we have a axillary nerve which is traveling into the quadrangular space. This is the radial nerve. So the axillary nerve is in very close relationship with the surgical neck. It is going and twisting around the surgical neck. Then the other important structure is posterior circumflex artery also twists around the surgical neck of the humerus. These two important structures on surgical neck of humerus, you are not going to basically forget it, doctor. Now, deltoid tuberosity, what is the importance of it? As the name says, it marks the insertion of the deltoid muscle, which is an important abductor of the upper limb. Then the spiral groove need to be remembered because it contains the radial nerve and the lateral head of the triceps above and the origin of the medial head below. Between the two, the radial nerve will be passing through the radial groove is what you need to remember. So in summary, we have a deltoid tuberosity, we have a radial fossa, and we have one radial groove through which the radial nerve is passing, which you should not forget. Then what is trochlea? Another important landmark. Typically trochlea is a spool shaped medial articular surface, and it articulates with the trochlear notch of the ulna. Trochlea and the trochlear notch of ulna. Trochlea is there in the humerus, trochlear notch is there in the ulna. Then what is meant by capitulum? It is the lateral articular surface along the distal end of the humerus. It is globular in shape and it articulates with the head of the radius. Then what is meant by Olecranon fossa? Basically the distal end of the humerus has got one Olecranon fossa in the posterior aspect. What is the importance of it? Typically the ulna is having this hood-like structure, no, olecranon. Whenever there is an extension, then the olecranon, this hood-like structure, will come and sit in the depression in the humerus called as Olecranon fossa. Where is it? Posterior depression in the humerus. So I am looking at an X-ray along the posterior aspect of the humerus, from behind of a person's elbow. Here you have the humerus, you have a Olecranon fossa, you have a Olecranon process, the hood-like structure of the ulna, which will go and sit in the Olecranon fossa whenever there is an extension. Then we have what is called as Coronoid Fossa. Please ask the students who are in online FMGE to come back to online MBBS. So tomorrow I am little more worried because we have a AIMS paper discussion. A lot of students will be logging in to attend. Thank God the technical error is only a day before. So coronoid fossa, it is typically an anterior depression above the trochlea, just like posterior depression is Olecranon fossa, anteriorly you have a coronoid fossa, and it accommodates the coronoid process of the ulna whenever we do the flexion of the elbow. So this is another way of summarizing the same. You have a coronoid fossa, you have a trochlea, there is a capitulum, and here you have a coronoid process of the ulna which will be accommodated by the coronoid fossa whenever we flex. Then there is another important depression anteriorly in the lower end of the humerus which is called radial fossa. Just above the capitulum you have the radial fossa. So the head of the radius is there, no? So the head of the radius, whenever you flex the elbow joint, will come and fit and sit in the radial fossa. So this is a radial fossa, there is one coronoid fossa, this is the capitulum, and this is epicondyle basically, and this is the trochlea. So this is how we recognize. Then what is the importance of the lateral epicondyle is my question to all of you. You know supinator muscle, which is an important supinator, and all the extensor muscles of the forearm. What is their common origin, doctor? It is the lateral epicondyle. So what is meant by tennis elbow and golfer's elbow? It is the lateral epicondylitis becomes the tennis elbow. Then medial epicondyle, it has got a groove through which the ulnar nerve will be passing, and also ulnar collateral artery will be passing, and it is the one which gives attachment to all the forearm flexors. In addition to that, the pronator teres and ulnar collateral ligament. Mainly pronator teres and supinator, what is their origin you should not forget. Pronator teres is medial epicondyle, supinator is the lateral epicondyle, is what grossly examiner want to check. Common flexor origin is medial epicondyle, extensor origin is lateral epicondyle, is what you have to be very sure. So this is how, doctor, the ulnar collateral ligament. Typically the ulnar collateral ligament has one anterior cord-like band, posterior fan-like band, and oblique fibers. They come and basically take an origin from the medial epicondyle, is what you need to basically remember. So this is another example of the flexor muscles and the medial epicondyle. Now comes the radius. Between radius and ulnar, they both are couple. Who is shorter? The husband radius is shorter than the wife ulna. Ulna also has a hood, right? So radius is shorter, it is lateral to ulna, and the distal end of it is fractured in Colles fracture, and in Colles there is a typical dorsal and radial displacement of the hand is what need to be remembered. Let us look at the radius. Radius has one head in its proximal end. This head will articulate with the capitulum of the humerus, and this head will be articulating with a notch in the ulna called the radial notch, and this head is surrounded by the annular ligament. What is meant by pulled elbow? Suppose if the mother says, don't run that side, the child will say, no, I am running. Then typically this annular ligament, from this the head will slip out. So once more you have a maneuver to bring back the pulled elbow back into the position, right? So the annular ligament is abutting the radial head fundamentally. So this is a typical radial head and the annular ligament, which you should not basically forget. Now this is another example for you to not forget. The radius head is up, but the ulna's head is down, and a radial styloid process is at a more lower level compared to ulnar styloid, and radial head has one fossa, radial notch in the ulna, and it basically coordinates with the capitulum of the humerus is what need to be remembered. Now coming to the distal end of the radius, the distal end of the radius will be ultimately articulating with the proximal row of bones. What are the various proximal row? She looks too pretty. She is scaphoid, lunate, triquetral. But pisiform does not articulate with the lower end of the radius is what you have to basically remember. So this is once more a classical example of what happens with the wrist joint. You can see the radial artery divides into one palmar carpal branch, and here is the scaphoid bone, and typically this the trapezium is what you are able to see. So radius distal end articulates with all the bones except the pisiform is what need to be remembered. Now there are some landmarks on the radius. There is one radial tuberosity in the upper end, and what does this tuberosity will be doing? Just like tibial tuberosity in the lower limb. So the biceps brachii muscle typically will have an attachment onto that radial tuberosity. That's the reason we need to remember. Now coming to the radial styloid. Radial styloid compared to that of the ulnar styloid is much more distal. 1 centimeter distal is what you need to know. And why the styloid need to be remembered? We have one brachioradialis, no? You remember we discussed forearm muscles in our first class of anatomy, right? So that inserts onto the styloid process of the radius. And if you look at the anatomical snuff box, you can be able to palpate it in the proximal part of the anatomical snuff box between the two tendons, extensor pollicis longus and extensor brevis tendons is what need to be remembered. Then coming to the ulna, what are the important structures? A very important structure is the olecranon. Why? Olecranon basically provides attachment site for the triceps muscle. There can be a fracture of the olecranon, which can be a simple transverse fracture of a olecranon, as what you can be able to see here. Then there is a capitulum for the ulna, and capitulum of the ulna is the site of attachment of brachialis. Then we have one trochlear notch, which basically receives the trochlear notch, the hood, which will be receiving the trochlea of the humerus. And the ulna also, just like radius, is having a tuberosity. Just like radial tuberosity gives attachment to biceps, ulnar tuberosity provides attachment site for brachialis is what need to be remembered. Then it has one radial notch, which we discussed, no? In the radial head will go and fit into the radial notch, and typically they form what is called as a proximal radioulnar joint in that location. Then ulna, just like radius, also has a head, but the radial head is above towards the elbow, whereas the ulnar head is typically below. Typically the head is the distal end in the case of the ulna, and it articulates with the articular disc of the distal radioulnar joint, and it also has a styloid process. Now, what are the various carpal bones? 1-2 comments about each of them for us to basically remember for the tomorrow's exam. Basically, she looks too pretty for, try to catch her 4. So 2 rows of 4 lateral to medial, we have scaphoid, lunate, triquetrum, pisiform, trapezium, trapezoid, capitate and hamate in the distal row. Now, except the pisiform in the proximal row, all the remaining will articulate with the radius, which we have discussed earlier. And what is pisiform, doctor? As rightly said by Dr. Harika, pisiform is considered to be sesamoid bone which is contained in the flexor carpi ulnaris tendon, is what need to be remembered, one of the favorite MCQs of the examiner. Then in the distal end we are having trapezium, trapezoid, capitate and hamate. So this is a typical alignment: scaphoid, lunate, triquetral in the distal row, hamate, capitate, trapezium, trapezoid and trapezium in the distal row, and the proximal row is scaphoid, lunate, triquetrum and pisiform. Now this is the general anatomy of the bones. Now 1-2 surgical points of importance. Ultimately in the exam, what is required is the surgical anatomy. There can be a fall on the shoulder on an outstretched hand, which can lead to fracture of clavicle. Similarly, obstetricians will do a lot of breech deliveries. Obstetrician breech delivery also is a risk factor for the fracture of the clavicle, is what you need to remember. Can you slightly raise the voice? Then whenever the infant presses against the maternal pubic symphysis during its passage in the birth canal, that is another important risk factor for the fracture of the clavicle, is what need to be remembered. Now, one of the common questions asked is, whenever the clavicle fractures, what is the very common site for the fracture of the clavicle? If you divide the clavicle into 3 1/3, it is the middle third which is considered to be the most common site for the fracture. Whenever the fracture occurs, what will happen, doctor? The proximal fragment, it will have an upward displacement because of pull of the sternocleidomastoid, and the distal fragment will have a downward displacement because of the pull of the deltoid. That is what typically happens whenever there is a fracture. Then there can be an injury to the brachial plexus, especially the lower trunk, whenever the fracture of the clavicle is there. There can be a fatal hemorrhage because of the bleeding from the subclavian, and there can be paresthesias because of the medial branchial and antibranchial cutaneous nerves pass in close relationship with the clavicle, is what need to be remembered. Then the second important surgical point of interest is superior transverse scapular ligament. We have seen no suprascapular notch. through the ligament it becomes a foramen through which suprascapular nerve will be passing. There can be a calcification of this and compression of the suprascapular nerve, and due to that supraspinatus, infraspinatus muscles can get affected, is what you need to remember. Then fracture of the greater tuberosity. Anyway, we will discuss this in a much detailed way in ortho, but what is the importance of this? Any direct trauma will lead to it. Any sudden contraction of supraspinatus muscle can cause a avulsion of the greater tubercle, and greater tubercle fracture is bothersome. Why? All the rotator cuff muscles, supraspinatus, infraspinatus and teres minor, their tendons are part of the rotator cuff and they take the origin from the greater tubercle. That's the reason we are very much bothered. Then what is the importance of lesser tubercle? Is the voice clear? No resound, right? So I request our online students to punch whether the voice is clear in transmission. Clear, very good. So whenever there is any posterior dislocation of the shoulder joint, often there is an accompanying fracture of the lesser tuberosity, and when there is a fracture of lesser tuberosity, subscapularis tendon is the one. So it is the lesser tubercle, this is the greater tubercle. So lesser tubercle fracture need to be bothered because subscapularis we have seen, no, from the inner surface of the scapula, that has a insertion into the lesser tubercle. That's the reason we need to remember. Then how about the fracture of the surgical neck after the both tubercles? The area is called surgical neck. In that area, axillary nerve, posterior circumflex, humeral circumflex artery, they are entering into quadrangular muscular space. They are the ones which can get injured whenever there is any fracture of the surgical neck, is what need to be remembered.